So I'm going to be doing my project on non-English speakers. And some of their main concerns are lack of healthcare access and the quality of that healthcare. And it's kind of hard, this population, just because the culture varies so much. Different people have different English proficiencies, various amounts of culture. They come from lots of different places, different length of time in the United States, different educational levels, employment status, income levels, and there's also not a lot of information of health status of non-English speaking populations because they're less likely to be involved in studies and in research. But the main problems involved are lack of access to primary care services, miscommunications due to language barriers, lack of insurance and underinsurance, low education and health literacy levels, and lack of diversity in research. So how does the media portray this population? So what I found when I was researching this was that immigrants are twice as likely to be reported in media for crimes, and 34% of immigrant characters in TV shows are associated with criminal acts, which is reinforcing that stereotype, even though immigrants are less likely to commit a crime than a native-born American. Immigration status is also overrepresented on TV. So about 63% of immigrants on TV are shown as undocumented or asylum seekers, when only 24% of immigrants in the United States are actually unauthorized. And then there's an underrepresentation of Asian and Pacific Islanders, only about 12% of media, and it's actually lowering that percent, make up media, when in fact it's they make up a quarter of the immigrants in the United States. Some of the good parts of media, though, is that a lot of their storylines can bring awareness to their stories and the hardships of coming over to the United States, which can help build empathy within a variety of cultures and help people to influence and take more action to help this community. So for family support, a big part of the population of limited English proficient patients are refugees and immigrants that might have come to the United States without their family, even though a lot of them are very family focused and love their families. That can cause poor compliance with lots of things. So they're going to be less likely to seek medical care without their family saying, hey, you need to go to the doctor, without insurance, and without family support. Family members who can be able to provide insurance for the family, there's going to be delayed annual exams, delayed dental care, and then increased complications. So if you think about it, when we are doing our discharge teaching with our patients, a lot of the times we're relying on their family members to help them with their new complex diagnoses, with their medications, with all the things that they need to do. And without family support, there's going to be increased complications and poor follow-up care. For cultural environment and the roles of peers, immigrants and refugees often experience social isolation when coming to the United States. They're coming here alone. They don't know the language. They don't know where to find a job, where to live. Basically, their whole world is upside down. So this can cause depression, diabetes from being in food deserts. Food security is sometimes poor. But a lot of studies showed that people that came to the United States and participated in support groups with peers, that they had an increased knowledge of food and resources and improved efficiency with dealing with their health problems. So I thought that was really cool. We love support groups. So the vulnerability of this population with these health problems passing on through generations. Technical difficulties. So through lack of education, low income status, mental health due to isolation, poor support, lack of social support, and likelihood of developing chronic illnesses are a lot more evident in the older generations, and this is probably due to lack of social support and time in the workforce. A lot of those younger generations, they're either in school or they're in jobs, and that can help navigate a lot of these things, the lack of education and income and So a lot of those older generations end up struggling long term. So the legal and political system can hinder this population. We kind of talked about it earlier with the media, the poor outlook and the poor image that sometimes the media gives to immigration status and to non-English speakers. And they often struggle to be able to obtain insurance due to legal status and lack of interpretation to get either insurance or to get employment. And this also causes decreased use in social services, partly because not being aware of it, not being aware of those resources, but also fear of deportation and immigrant reinforcement. So seeking healthcare can be really intimidating for this population due to fears of being deported or for language barriers. And often our political and legal system changes so much, and not knowing the language to be able to interpret the laws can just prevent healthcare visits in the first place. Potential barriers. So again, this population varies with culture because there's so many different cultures that are involved. But because they are limited English speaking and coming to the United States, the lack of support and the lack of resources in their primary language can put them at a disadvantage when it comes to health. We often don't realize the amount of health education and help that is provided for us as English speakers through the media, through work, family, friends, just our culture from growing up, and it's often missed in this population. Another thing with like religious views is that some cultures view illness through a religious perspective, meaning that health complications can be seen as not having enough faith in God or a result of sinful parents. So sometimes it's important to keep that in mind when educating with your parents I work at a children's hospital, educating with your patients and their families and helping them understand diagnoses and treatments. So the regions of the world where this population would be in danger. So a lot of non-English speakers come from different places in the world that they are experiencing violence, and that's why they come here. Most are leaving situations of collective and sexual violence, torture, homicide, and that can lead to mental health problems like depression and emotional distress, suicidality. Many can come here already experiencing physical health problems like injuries from their journey over here, pain syndromes, arthritis, coronary heart disease, probably from stress and diet. Sexual health problems. A lot of the women come with STIs, vaginal bleeding, UTIs, miscarriages, preterm deliveries, and neonatal death from that sexual violence that they experience. So socioeconomic status. There's a large variety of needs among the population of limited English proficient people in the U.S. Because of the wide range of cultures. But immigrants often come from other countries, so that puts them at a disadvantage for obtaining employment, which puts them at a disadvantage for obtaining resources and property and health services. It's really hard to find a job if you don't speak English, especially a good job that provides good insurance for large families. And this can be a huge disadvantage for this population. So it can cause non-adherence to medications because they don't have the ability to afford them. They're less likely to get the education and the screenings that are going to prevent diabetes, hypertension, cancer. Less likely to get treatment for chronic illnesses, which makes them worse. Less likely to seek primary care, psychiatric care, emergency care, prenatal care, oral care, all of the cares because of low-income households. And they're also can live in food deserts, which puts them at higher risk for all of those diseases that I already talked about, and usually makes it so they have less education as well. So with race and ethnicity, I'll talk a little bit more during discrimination from care in the biases part, but a big part, kind of what we already talked about, of lack of insurance. puts them more at risk for cardiovascular disease, cancer, type 2 diabetes, obesity, hypertension. Even though those diseases are the highest in all of us in our population, if we're not going to the doctor to get our blood pressure checked, which you're not going to if you don't have insurance or if you don't know that you're supposed to go in when you're having abnormal symptoms. So that lack of health literacy and you don't speak English to be able to learn about those educational things that are provided, and then lack of prevention and screenings. Those are all struggles that can come with that. Health disparities with gender. So women refugees often, we already kind of talked about this earlier, about leaving situations of sexual violence and having increased problems with PTSD, depression, suicidality, but also reproductive problems. They either can come over here with those reproductive problems or not feel like they can seek help. Lack of education for second generation is also a big thing, just because they come from a variety of different cultures who see sexual health differently and sometimes through a religious lens. I once had a patient at LDS Hospital. She was from Mexico, but she only spoke a little bit of Spanish because she was part of the indigenous population. So, of course, she was having all of these symptoms during her pregnancy, but she didn't feel like she could seek help because she didn't have anyone that spoke her language. And so she put off going to the hospital until it was an emergency, and she had her preterm baby, and she was actually diagnosed with stage 4 cancer, which she definitely could have gotten help earlier on, which would have made it more likely that she would have survived that cancer and probably would have helped her baby to be a little bit healthier too. So I think things like this happen a lot to women that don't speak English. Male immigrants are more likely to work in unsafe work environments like mining, lodging, agriculture, and construction, which can bring on a lot of risk. Those are some of the riskiest occupations when it comes to health and workplace injuries. So biases. A lot of these limited English-speaking patients are less likely to build trust and rapport with their providers from biases on both ends, from the provider and from the patient. And then some providers lack the cultural competency to be able to help these patients with their health problems. And visits with providers are often seen as time-consuming because of the use of interpreters and because of miscommunications. And so I see this a lot with providers and nurses just avoiding even going into the room with non-English speakers just because they know they might not have time to stay in there a long time, which kind of sets these people up for poor relationships with their healthcare providers. And then a lot of them fear inquiries about their immigration status, so they avoid going into hospital and seeking care. So areas that would have less influence on health for this population. High density areas like cities and states with frequent immigration like California, New York, Texas, Florida can provide a little bit more support through culturally and language trained providers, more resources in their primary language, more support groups that are available in their language, and just a better community, which improves their health overall. Salt Lake has a lot more resources for Spanish speakers than the rural areas of Utah, but California probably has a lot more than us. California has more resources for Asian communities and Pacific Islander resources in their language. So when they live in higher populations with their language, their health outcomes are higher and greater. So sorry that was a lot of talking, but they're all my resources.